So I've been a registered nurse in labor and delivery for over 12 years. I have had wonderful experiences, I've had sad experiences, but there's one experience that for me was career changing.
I was on my way to work and she called me and told me that her back was hurting really bad. And I knew that she's been having problems with her back for a couple of weeks. And I jokingly said, "Oh, come into the hospital and I'll take care of you." And she laughed it off and she said, "Okay, I'll call you later." About 2 hours later, her husband called me and said that they were on their way to the hospital and she wanted to come to your hospital because you were there. Meet us in the ER.
Mary had presented to the emergency room with complaints of intense back pain, shortness of breath, fever, and chills. Her pulse was rapid at 166, as well as her respiratory rate of 34. Her blood pressure was 138/66, her white blood cell count was 4, and her urinalysis indicated that she had a current urinary tract infection. Her temperature was 100.9 degrees. The emergency room staff quickly tried to determine the cause of Mary presenting so acutely ill. Arterial blood gases revealed an oxygen saturation of only 79%. Her current respiratory and cardiac condition initially led her doctors to suspect a pulmonary embolism or sinus ventricular tachycardia. Mary was given a dose of Lovenox to potentially treat a possible pulmonary embolus.
It was in the ER that she was in more pain than I could have ever imagined. She could barely breathe. She was feverish. She just didn't feel good, and we had no idea what was going on. The ER ran a bunch of tests, and it was when we were waiting for those tests that she confided to her husband and I that she might be pregnant. From then, the ER did a pregnancy test and did an ultrasound, and that's when they saw the fetal demise.
The pain that Mary was experiencing was labor, and the unknown pregnancy had caused her to become infected, very infected. Mary was septic. Mary was brought to labor and delivery, where the plan was to get her delivered as soon as possible. Mary's OB/GYN had consulted with perinatology and anesthesia. Everyone was in agreement that a vaginal birth was the route that would cause the least insult to such a sick girl. When I assumed her care at 7 a.m., she was not completely dilated. Her initial WBC was now 14, blood pressure 117/80, her pulse 150, and her respiratory rate was 34. She kept complaining of back pain. It was extremely difficult to connect the patient to the condition. Here was this young, beautiful girl who looked like any other patient about to have a baby. I remember then looking up at the EKG, and her respiratory rate was in the 60s. Her labs were redrawn and were getting worse. Her white blood cell count was now 21.7, and she had a lactic acid of 12. She was now showing signs of DIC, a complication of sepsis. Her platelets and fibrinogen were dropping with a prolongation of her PT and PTT. We just needed to get the baby out. This was the source of the infection. The doctor examined her and announced that it was time to start pushing. We were even prepared to use a vacuum to help expedite this stage. Mary pushed 2, maybe 3 times before her oxygen saturation dropped. We stopped pushing. I noted that the BP, her blood pressure, was 67/40. Her oxygen saturation was dropping to 77% despite giving her oxygen. She recovered, but it was now more urgent to get the baby out. The doctor applied the vacuum. Mary pushed once more, but this time her lips turned blue and she fell forward.
That morning I got off work and I went into her room with her husband and her, and I don't know, 20 minutes later she coded.
Mary had gone into respiratory arrest. Within minutes, more staff than I could count were everywhere, working to revive Mary. I can still hear Mary's husband screaming in the hallway, pleading for her to come back. Mary was only 26 years old. She had a daughter, a newly adopted baby boy, and she never recovered.
Sepsis remains one of the major causes of death in a hospital, and it's one of the major causes of maternal mortality as well. Infection occurs. Bladder infections, skin infections, or infections in the uterus. However, when an infection proceeds far enough, certain signs and symptoms present, we consider something called SIRS, or systemic inflammatory response. This is the body responding to the infection. When we have a site of infection, and we have certain of these SIRS findings, that leads us to the diagnosis of sepsis. Most infections do not lead to sepsis. However, when they do, we need to be very aggressive with the treatment and handling of these patients to prevent severe injury or death. Infection and sepsis in pregnancy often is missed because we think it may be a normal finding in pregnancy.
Sepsis was an issue that we were barely understanding, that really was taking the lives of many of our patients. And we worked very, very hard to better understand why that was something that we were unable to be on top of, and why we were seeing very young people who were dying of sepsis. So we put together an entire team to look at the patients who have come in and experienced sepsis and tried to determine what it was that we were missing. We did a lot of research, and there were a lot of hospitals ahead of the curve who were far ahead of us in early recognition of sepsis for these adult patients. And by recognizing early, we're also able to intervene earlier and make a difference in their outcomes. It was a lot of work by a lot of people. It was a team of doctors, nurses, statisticians, social workers, all of the people that it's required in order to recognize sepsis as well as provide the therapy to change their outcomes from what we had seen. So when we started with the obvious. We started with those patients that were adults. And then as we became adept at identifying patients with sepsis, we started to see just a trickle of patients who were leaving labor and delivery or leaving high-risk maternity and needing to be up in the ICU because they were presenting with those same signs and symptoms. And it was the people from the women's and children's area who could raise their hand and say, you know, I think we have this problem in a population of patients that we've ignored. It was at that point that we recognized that it is not, sepsis is not unique to an adult med-surg population. It is something that really crosses all of the populations of patients we serve.
When our patients, the perinatal patients, develop signs and symptoms of infection, because they're young and healthy usually, they compensate for a long time, but then all of a sudden they decompensate quickly. When we started screening, we identified approximately 6 to 10 positive SIRS criteria every month. So they really didn't have severe sepsis yet, but they did give us the signs of systemic inflammatory response. And since this was new to us, we asked the rapid response team to come and help us screening, help us with the discussions with the physicians, and following the toolkit and management of these patients. When we looked at the screening tool, though, we identified some of the triggers that may give us false positives because of the physiology of pregnancy. Would change those values. An example is the heart rate. A pregnant patient has increased blood volume. They have a 10% increase in their heart rate. So we had to increase the heart rate value so that we wouldn't get false positives. Another phenomena is the increase in white blood cell count during labor and postpartum. And if we use the regular adult population tool, we would have had many false positives. So we changed it based on that and what we found in the literature, and educated the physicians and the nurses, and began screening.
Because we're nurses at the bedside, we have a very key role with our patients. Our population is very young, usually healthy. Pregnancy, everybody expects it to go smoothly, but because of the changes in pregnancy, it can be very important to be diligent to screen for sepsis, because it can kind of, if you will, sneak in and really cause a lot of damage very quickly for our patients and for our babies.
When it comes to preventing the infections that lead to sepsis, there's really 3 infections in obstetrics that will most commonly get there: wound infection, pyelonephritis, and chorioamnionitis. So if we take each one of those, wound infection, we do a number of things really well here to try to prevent that, and we've gotten even better lately. For instance, wound preparation, the antiseptic we use, the drying that we use, sterile technique that we use within surgery. Probably the best thing that we've done lately is we've moved the administration of antibiotics from the time of cord clamp to 60 minutes prior to the surgical incision. So we've gotten in line with most other surgical specialties. We used to give it after cord clamp because we worried about the effect it would have on the infant's workup, but we know now from the pediatrician literature that that isn't a concern and that we should give it at the best time for the mother, and that would be within 60 minutes of the surgical incision.
Selecting an appropriate antibiotic for a peripartum patient can sometimes be complicated, but we try to pick antibiotics that, one, get to the site of an infection that we think is happening. We pick antibiotics to cover the organisms that may reside in that site, and if patients have been in the hospital for a while or have other comorbidities or previous infections, we try to use microbiologic data to help us make those decisions. With this population, we're always looking for bacteria that inhabit the GU and GI tract. And these tend to be a lot of strep, including group B streptococcus and even enterococcus. We see a lot of anaerobes, especially in the gut and in the vaginal area. And of course, if they're getting procedures, going to surgery, we worry about strep from the skin and even Staph aureus from the skin. And sometimes it can be MRSA, which we're seeing more and more in the community as colonizers of the skin.
So it's very important that we, as clinical practitioners, always keep in our back of our mind these systemic inflammatory response signs and symptoms in an effort to catch sepsis before it becomes severe sepsis or septic shock.
The obstetrical sepsis management pathway is a teaching tool for RNs. It serves as an algorithm for decision-making for management of patients screening positive for sepsis. In order to recognize and manage a patient with sepsis, we must look at sepsis as progressing on a continuum. Intervening early when the patient is screening positive for sepsis is recommended to reduce mortality and improve patient outcomes. Let's start at the beginning. At the top, a patient presents with a new or suspected infection. The nurse evaluates for 2 or more SIRS criteria to determine if the patient has sepsis. These SIRS criteria were adjusted for pregnancy as the physiology of pregnancy mimics the systemic inflammatory response. Let's take a look at these criteria. Temperature is greater than 100.4 Fahrenheit. Heart rate is greater than 110. Respiratory rate is greater than 24. White blood cells are greater than 15,000, or WBCs are less than 4,000, or greater than 10% immature neutrophils. A new mental status change, or the blood glucose is greater than 140 milligrams per deciliter in the absence of diabetes. If the patient has 2 or more of these SIRS criteria, the patient screens positive for sepsis. The following interventions are recommended for early recognition and management of sepsis. The RRT is an integral team member to consult when a patient presents with sepsis. The RRT assists the nurse with assessment, makes recommendations for management of care. The RRT confirms a positive sepsis screen and initiates stat labs per RRT standardized procedures. This would prevent delay of sepsis workup and ensure that every patient receives the same workup for sepsis in a timely manner. The RRT can initiate a sepsis alert, which is an overhead page to mobilize team members such as lab and additional team members to quickly intervene to draw stat labs, place an IV, and administer first broad-spectrum antibiotic. The interventions that are bolded are considered mandatory and the guidelines considered recommended per the Surviving Sepsis campaign. A serum lactate, complete blood count, and blood cultures must be drawn. Depending on the clinical pictures, a CMP, PT, PTT, INR, serum creatinine are the additional labs that would be requested. A recent serum creatinine to determine kidney function is required for patients on broad-spectrum antibiotics. A PT, PTT, INR, and platelet count can determine coagulopathy or signs of acute organ dysfunction. Urinalysis is indicated for the patient presenting with urinary symptoms such as a urinary tract infection or pyelonephritis. Blood cultures are to be obtained prior to giving the antibiotics, however, should not delay administration of first broad-spectrum antibiotic. If the patient does not have an IV, one must be placed. A broad-spectrum antibiotic must be given within 1 hour after sepsis is identified. The type of antibiotic is dependent on the source of infection. A chest x-ray must be done if the infection is in the chest cavity. Continuing on the pathway, the clinician must assess for a presence of organ dysfunction. If the patient displays any sign or symptom of organ dysfunction, the patient has severe sepsis. Let's look at the features of acute organ dysfunction. Lactate above 2 millimole, systolic blood pressure below 90 or MAP less than 65, or if the systolic blood pressure decreases less than 40 from baseline. Bilirubin greater than 2 milligrams per deciliter, a new or increased oxygen requirement to maintain oxygen sats above 90%. Urine output below 0.5 milliliters per kg per hour for over 2 hours, or a creatinine above 1.5 milligrams per deciliter. A platelet count below 100,000, coagulopathy with INR above 1.5 or PTT above 60 seconds. If the patient has one of these symptoms of acute organ dysfunction, the patient has severe sepsis. The following interventions are recommended for severe sepsis. Give IV fluids normal saline 30 ml per kg now. Call the rapid response team nurse to the bedside now. Repeat lactate every 6 hours times 4 or until the lactate is below 2. Urinary catheter must be considered for strict INO. Monitor oxygen saturations and give oxygen per protocol. Notify MD of signs of organ dysfunction. Consider to change antibiotic to a powerful broad-spectrum antibiotic such as Zosyn or cefepime. Continuing on the pathway, the clinician assesses for septic shock. Clinical features are the same as severe sepsis. However, the distinguishing feature is profound hypotension with systolic BP less than 90, MAP less than 65 despite fluid resuscitation, or the lactate is greater than 3.9. If the patient has any of these features, the patient has septic shock. The following interventions are recommended for septic shock. Powerful broad-spectrum antibiotics, combination therapy is preferred. Call the rapid response team nurse to the bedside. ICU admission must be considered. Anesthesia at the bedside now. IV fluids, normal saline 30 ml per kg now. Consider central venous access. In order to initiate the interventions in an efficient, timely manner, implementing a code sepsis, which is an overhead page to mobilize some of the team members to the bedside quickly and to alert other team members of a patient with septic shock in the hospital. Team members such as the lab, RNs, pharmacy, ICU, house supervisor, hospitalist, or an RRT can rapidly respond to either support or implement the sepsis bundles.
One of the reasons that we chose to do the sepsis initiative was, first of all, it was very important in the adult world. And there was no real understanding of what needed to be done in the perinatal world. I think that we have made some real strides in raising nursing awareness as to what sepsis looks like, catching it earlier, being more aggressive about our interventions, understanding the necessity to be aggressive, and also, well, I think we've had some really significant impact on the neonatal population as well, which we weren't thinking about when we started this initiative. We were just thinking about moms.
The sepsis screen is a very clear and easy tool to follow, a recipe, if you will. And with healthcare providers using this tool, we can work together to implement early detection, intervention, treatment, and management of sepsis for our patients.
Using our blood cultures, we can very quickly narrow, if we have a positive blood culture, to an agent that's most effective for that agent. We can also de-escalate based on patient response. So we start to see their white count come down. They're no longer having lactic acidosis. We see that their temperatures have stopped they've stopped having fevers, and we can de-escalate to maybe, especially if there's a negative blood culture, what we think was the most common organism involved, and we'll de-escalate to a 1-agent regimen as opposed to the 2 or 3 agent regimen. And we like to do that usually with about 72 hours. That helps to avoid toxicities of these drugs, because these drugs can be toxic, and no drug that's given to a patient is without the potential for a reaction. So we want to make sure that we go ahead and do that as quickly and efficiently as possible to these patients.
And then if you look at chorioamnionitis, I think that's one thing we can do all here as a team together, both nurses and physicians, trying to prevent prolonged labors. If we do less inductions, so that would help. Certainly once a woman has her membranes ruptured, if we can do less vaginal exams. Both physicians and nurses now are trained on ultrasound location of the vertex, so we don't have to do that first vaginal exam.
It's crucial that we educate the physician and nursing and ancillary staff to be prepared for a woman who presents with sepsis or who develops sepsis during her hospital stay. Because it would be a tragedy to miss a case of sepsis that ended up in death that we could have prevented.